Good afternoon, ECHO family. Welcome to this afternoon's ECHO presentation. And we are happy to be here with you again and just to interact across many kilometers and just to have this sort of updates regarding the program in our health. And so today, we just want to welcome one of our the networks that has joined us for the first time, and probably they've been here. We didn't recognize them. That is Usakili in Kitwe. Welcome. We're happy to have you on this network. We also want to welcome many others that have not been on the network before. We recognize you. Say welcome to this network. And also we want to thank the people that are working so hard in the COVID centers, Kotia, Devi, Masaiti, now Nakonde, and other places like Livingstone, and all those we really welcome and appreciate your work that you're doing out there. So this afternoon, we're privileged, we'll be having Professor Mulenga coming to address us on the issue of providing quality quality health services.
Okay, I'm good. Sorry.
And so,
hello.
And so we would like to just remind the network that let's be mindful of the teleconference etiquette that we always advise on. We mute ourselves if we are not talking. And then also we make sure that our videos are stationary and they're not, you don't have a lot of movement in your background. You're using your mobile phone. And that let us also be well positioned wherever we are in our private places so that, because most of these sessions are recorded and we don't want to record anything unusual. So we'll start this afternoon session with an update from last week when we had a great presentation by Dr. Agre Mwemba. He was looking at COVID and NCDs, particularly cardiovascular diseases. So in the hub, we have one of our experts, Dr. Seville, and we also have our pharmacist, Mr. Davis Kampamba. And then also we have in our midst our own pharmacist here at PCOE as well joining us. So I'll hand over to Davis to give us an update for this afternoon. Thank you very much.
All right, thank you so much, Kozia. So as he has mentioned, last week we were looking at COVID-19 and the NCD comorbidities in relation to, of course, COVID-19, as I have mentioned, and it was noted that there was a high prevalence of diabetes mellitus and cardiovascular diseases in COVID-19 patients in China and USA. To be specific, in those that were hospitalized, severe COVID-19 patients, diabetes mellitus and hypertension, including cardiovascular diseases, were seen to be more prevalent in the two given countries, that is China and USA. And then those with pre-existing cardiovascular diseases, they seemed more prone to severe complications of COVID-19 with increased mortality. So it was noted that NCD comorbidities actually seem to worsen the disease progression in the COVID-19 patients. And then, of course, looking at the mechanism of injury in CVS, we are told that actually these are multifactorial and included something like direct cardiotoxicity, viral-driven cytokine storm, to mention, but just those. And treatment for this is directed at the specific cardiac pathology. We also looked at cardiovascular, not cardiovascular, but COVID-19 and venous thromboembolism, and we noticed that actually that patients with COVID-19 are at increased risk of venous thromboembolism. Of course, this was attributed to prolonged immobilization, propensity for disseminated intravascular cardiomyopathy, hypercoagulable status, and active inflammation. Then for those with DVT, that's COVID-19 patients, we found that in ordinary patients, it was 22.7% increased risk compared to those that were in ICU, and that was placed at 27%. And then the COVID-19 patients was seen that have higher level of D-dimer, fibrin, and fibrinogen compared to the healthy individuals. And then concerning the summary of the first 41 PCR confirmed COVID-19 patients that we had in Zambia, in relation to age and cardiovascular diseases, 23.5% were 50 years and above, 10% were hypertensive, another 10% being diabetic, and then hospital stay, of course, was longer for those with hypertension and diabetes mellitus. And for the mortalities, we had one female was 80 years old with a stroke and hypertension, male 48-year-old with hypertension, and a female 30 years with cirrhosis and hepatic encephalopathy, and another 38-year-old male with acute kidney injury and HIV, TB, and TB as well. And then female 19 years old due to poisoning, and then male 58 with hypertension and stroke, brought in shock with suspected myocardial infarction, and last but not the least, male with KS and HIV. So that was just a slight a summary of what we had last week as we were looking at COVID-19 and the NCD comorbidities. Thank you. Over to you, Kozi.
Thank you very much, Mr. Kampamba, and very great reminder. It was a great session. So today's session, like I said, we'll be looking at ensuring quality of HIV services during the COVID-19 pandemic. As you may be aware, we do have also an HIV pandemic even in this situation, and we've actually worked hard and gained a lot of milestones in that fight. And so we want to continue on that trajectory. So as we even face this pandemic, we thought it was important that we also look at some critical areas and when it comes to the HIV program. And so in our presence this afternoon, I would like to just welcome Professor Mulenga, Technical Director, Infectious Diseases, Ministry of Health. Your floor.
Thank you so much. I'm coming from an area where we're putting on masks all the time. So it's okay if I use the mask while speaking?
Very loud and clear, I think.
Good afternoon, friends out there. This afternoon, our discussion will center around sustaining HIV services, and not just sustaining these services, but ensuring that there is quality to the services that we are providing, even during this COVID-19 pandemic. Why are we doing this? We're doing this because we know that it's important for us not to lag behind in the HIV service delivery area, despite having the COVID-19. And the successes which we had before the COVID-19, we need to maintain them. And also, I'd like to highlight on the status of this epidemic, the COVID-19, where we are. And as I said, we need to have a closer look at the treatment gains which we have made, even during this pandemic.
So we'll be moving now to the I'm going to share the pause for this afternoon, and then we'll be expecting the network to participate and get involved. So we're expecting everybody to begin polling. So the first question here says, this is true or false? HIV epidemic control is when total number of new infections falls below the total number of deaths among people living with HIV, with both declining. Is this statement true or false? When we discuss and when we talk about epidemic control, what do we mean? This is what this question is trying to find out. And as the HIV program has been talking about epidemic control by 2021 and as we go. So what does this mean to us? Is this statement true or false? So we have about 139 connections. So we are expecting a lot more people to vote in. And so far only 72 have less than half, or just about half have voted. So kindly participate and let us know what you think. Okay, so I have a few seconds and I'll end the poll. Thank you. So we'll move on. I just show you. So this is a voting pattern. Most think it's true. Some think it's false. It's a false statement. Okay, so I'll stop sharing and then we can look at the second poll. So this one is asking, what is needed to break the HIV transmission cycle? What do we need to do to break the HIV transmission cycle? A, ensuring majority, at least more than 80% of people living with HIV are on treatment, including men. B, finding new cases. C, retaining people living with HIV in care without treatment interruption. D, all of the above. What do you think is going to interrupt the transmission cycle? Is it A, putting all the people that are living in HIV on treatment, including men, at least having 81% of them, or finding new cases, or retaining people living with HIV in care without treatment interruption? I think this one will seem to be doing very well. I think most people have voted, over 60%. I think we seem to understand what transmission cycle is. Okay, so just a few more seconds and then I'm going to end the poll so that we can allow Professor to continue with the presentation. All right, thank you very much. I'll end the poll here. Prof, please, you may take over.
Thank you so much, Dr. Kozia. So friends, we have to ask ourselves on why is it important to maintain the quality HIV services despite the COVID-19. When you look at the HIV epidemic control in Zambia, what will it take us to attain this? If you look at the blue line there, we are seeing this is the number of new infections. I don't know what color that is, that Dr. Kozia says it's an orange one, which is showing us the number of deaths among people living with HIV. Now for us, what we want to achieve is we want to have a less number of the new infections, compared to the number of deaths. But importantly, both of them should show a downward trend. And that is very key. Because only if we achieve that, then we know that we are having less new infections which are happening, and that is very key for us to reduce the transmission of HIV in the country. Now, the danger which we have, especially during the COVID era, is that we can lag behind, concentrate on the interventions for COVID, which we know are very important and may have an effect on overall HIV programming success if we do not attend to them. But at the same time, we need to maintain those measures which are also going to help us achieve HIV epidemic control. As a ministry, currently, we are working on a paper of sustaining health services in the ministry during the COVID pandemic. And in this, it's addressing all the other issues, not just HIV. We're looking at TB, we're looking at malaria, we're looking at vaccines. All these services, we need to ensure that we are on top of them, even as we tackle the COVID-19. Now, we know very well where the transmissions are happening, and we know the groups where we have these populations of HIV in terms of transmission, where the prevalence is high as well. The women, 25 to 40, have a high prevalence of HIV. And if you look at this age group, they are the ones who are feeling the transmission to the men, 25 to 40 years old, because they have this high prevalence. Then the men who are in the 25 to 40 are the ones who are transmitting to the young women under 25 years old. And again, as you can see, the young women under 25 years old, over time, they'll age, they'll go into the population of 25 to 40. And this cycle has to be interrupted, else there will be continuous transmission happening. Now, we can do that if we put those people on treatment, find them. After we find them, and this does include the men as well, we return them into care, and we ensure that the viral load is suppressed. Let's just remind ourselves on what we have done as a country before COVID-19 pandemic. This is showing us the progress which we have done like last year from, this is paper data from Q1 of last year, the FY19 to Q4. And you can see some smooth rise in the number of patients, adults, and also pediatrics who are putting on treatment from 831,140 to 976,691. And you can see that even the pediatrics, even though we started at 40,000, now went up to 44,000. And when you compare again to the targets for even for the Q1 of 20, you can see where you have now 962 for the adults, 664. And if you had to look now against the overall target, the national one, where you now move to 996,541. And the yellow one, the green one is the one which is national. But if you look at the orange bar is describing to us, if we had to achieve 100% coverage, then we would need to go up to 1,240,247. Now, we can only achieve, our target is to achieve the last bar. And achieving the last bar entails that we need to effectively identify the new cases. Again, we need to remind ourselves that as long as we have the new cases, they're not put on treatment, then the transmission will still continue going on. Look at the progress again from 2019, previous slide. In terms of identifying the new cases. Q1 of FY19, and again, this is the American calendar, not aligned to the Zambian calendar. You look at that, you see the 4.4% yield which we are having, and it's now increased to 7.4% yield. Now, if you look at FY20 Q1, this is part of the COVID era as well. It's overlapping with the time that we had the COVID. So we need to maintain this trajectory for us to achieve the HIV epidemic control. We are not, as a program, we are not saying we are not going to achieve HIV epidemic control. We will achieve HIV epidemic control. So we need to work hard despite the COVID-19 pandemic. We have to achieve HIV epidemic control. And again, this is reminding us again of the great work largely attributed to you people out there, is the retention. We look at 2017, FY17, we had the retention rates, current on treatment 73. Look at those who were lost, 26.7% female and 27% male. That in FY19, again, there wasn't much reduction, but there was a slight increase for the male. But in FY19, these numbers changed with 10.74% in the female and 11% in the male, with an overall current on treatment of 88% in the male and 89% in the female. Now, all this is because of measures which were put in place, identifying that if we do not really look at those individuals whom we are losing on treatment, those who are falling out, there will still be continuous infection which is going to happen. And the interventions which are put in place, we need to maintain them, friends. Another success area has been the viral load coverage and also viral load suppression rates. I remember 22 years ago, thinking of how we can raise the coverage to 80%, the target which we had. And I thought even when we were giving guidance and also when we were setting up the viral load task force teams, I thought it would be possible to achieve what we have achieved. We're talking of then of 32% coverage. Went to FY19 Q2, 53%, and look at where we are with close to 75% coverage. This has been tremendous work done. We appreciate the resources which have come in from the partners, like the US government and the Global Fund as well, in trying to scale up this. But we also thank you out there who have been able to, even when we are pushing, you've been able to accept these interventions which are put in place. The lab team has done great work in accepting the modifications to the way that we do things. The courier system has improved, and we are now using that same courier system to help us also improve the courier system for the COVID-19 samples. And when you look at the viral load suppression, we have also moved from 83% to 92%. I think you've done well out there, including the people who are in here.
I think they can give themselves a pattern.
Yes, please. On the back.
Yes, since we can't hear the clapping.
Oh, yeah. So I think really, colleagues out there, you've done so much great work, and we are really proud of what you're doing. Let's continue with this momentum. Now, these are our program priorities, which we have discussed several times. DTG tough transition, HIV testing with efficiency, scale-up of the GSDs, appointment and also tracking systems, how do we optimize them? The SAGE in the TPT, the elimination of HIV and syphilis, mother-to-child transmission, active pharmacovigilance, the rollout of Project ECHO, HIV research testing, HIV drug resistance surveillance, and also the Zambia as well, which was one key component. These have been affected by COVID-19. We haven't been able to move at a rate we're supposed to move in implementing those activities, and we know that those have a direct bearing to achieving HIV epidemic control. So friends, expect that in the coming months, at least now we understand the burden which we have of COVID-19, but in the coming months, friends, we are going to continue implementing those activities so that we don't lag behind. We are going to do it in a safe space, in a safe area, or else if we don't go there, we'll wake up and discover that we have created a bigger problem in the HIV service delivery system. We are going to do it within the confines of the law. We are going to do it within the space which we have. We do it safely, but we need to move this agenda forward so that HIV doesn't lag behind. Scale up of the effective drugs. Now, this is a key and it's a game changer. DTG-based therapy have to be given. 70% of all adults on treatment should be on DTG-based therapy. We are hopeful, Dr. Sivile, that back to TLD. And in preparing for that, let's do even the viral loads to those individuals who haven't had a viral load done. So come October, November, we are going to have a robust transition of patients from TLE to TLD, and we are hopeful we can even achieve 80%. The stockpiling of the commodities which is happening right now will make us reach that. But importantly is we are pleading for you out there to work with us. I know we've been pushing a lot of things, a lot of interventions. Continue working with us and continue accepting these interventions because we are hopeful that we are going to achieve these targets of us having DTG available to the people that need them. Larger population of 80% by the end of this year. We can only do that if right now we prepare ourselves, we prepare the clients. Let's talk to our clients in a nice way. I know we've disturbed them by moving them from TLD to TLE. Let's prepare them to be ready for a mass transition should that time come, which will be likely in September, October. TPT SAGE is another area which we've done so well. Friends, let's continue giving the TPT. Right now, because of the challenges with COVID, we don't know as well when we are supposed to have introduced the 3HP, but you'll be informed when we have these commodities available. For now, the message is let's initiate our clients on the TPT. For now, as it is available with B6, let's give our clients those. Cervical cancer is also another area we have seen some improvement in the way that we are rolling out the services of cervical cancer screening for HIV infected people. And let's move on. And for those that have lesions which need intervention, either lip, cryo, or thermal, let's move on and provide these services to our clients. And this is no time again to lag behind to say, no, we cannot screen for cervical cancer because of COVID. We can screen even in a safe space. Now let's briefly look at the general picture of COVID-19. Now, this, I'm sure, these are of 16 May. It does not include the cases that were reported yesterday, cases reported today as well. But this slide is just trying to give us an indication of where we are and where we have seen these numbers increasing from. We have seen that we started slowly with those 2 patients. Then, of course, we had a number of infections which came in from Pakistan. Then there was a time when we thought things were under control. Then we started seeing a number of cases, small cases. I remember when we had about 8, 9, 8, the whole week. Then came the Copper Belt as well, started recording cases on the Copper Belt. And then Akonde just taught us that things were not okay in the country. With Akonde, with the initial 76, thought that this may be the highest. Then of course came the 174, then the 208, then remember again what we saw again in Lusaka, the 74 cases reported yesterday. Again, this just tells us that the burden of COVID-19 is high. We thought Nakonde was the highest, but look at what came from Lusaka yesterday. Similar thing can happen as well if we don't program well in the HIV area. We can concentrate on this, but not knowing that there's a bigger problem also growing up in HIV while we're concentrating on COVID. So these are the cases which we have been seeing. And we are still testing. Some of us spent good 4 or 5 days in Nakonde to understand the burden of the problem. And we see that there are likely more cases are still there. But also when you look at Nakonde, the people in Nakonde, they travel to Mbala, they travel to Kasama, they travel to Chinsali, then they travel to Mpika. And the truck drivers from there, they go all the way to Kasumbalesa, some Livingstone, other countries as well. So this problem which we have, friends, it's not just limited to Nakonde, it's not limited to Lusaka. We have a bigger problem and we need all our heads together for us to sort out this problem. But the other services should not suffer. The next slide is showing us, besides the increase in the cases, we are also seeing the recoveries. We have had a relatively good number of people who have recovered. Even the people that we thought we may lose, they've really, really done well. And thank you to a multidisciplinary team based in country and also outside the country. I can't mention the names, but we have teams from within the country, we have teams from the US, we have teams, members of that multidisciplinary team also from Europe as well. And when we have these challenging cases, they've come on board to help us address those. And we have seen better outcomes, even in the patients whom we thought we were going to lose and we had lost hope. The pediatricians, I need also to commend the pediatricians, Dr. Kozia, your team, Dr. Mwenechanya, they've done very well.
Thank you. Thank you.
And tell your fellow pediatricians that sometimes us as physicians, we talk a lot. And sometimes we try to confuse you. And now on that child who is now okay, you were just bombarding you with a lot of things to do, some of them theoretical, which we cannot do. But the pediatricians have done a fantastic job. So well done, pediatricians. And Dr. Manoj should be proud of the team that he has. And I think the teamwork has helped us save a number of these children. Now, this is where we are again, the district where the cases have been reported. I've seen that my district where I stay, oh, it's there, Chilanga. Small community, but we are seeing 26 cases. But I can assure you it's not me who's carrying those cases to Chilanga. I'm very sure, sir, because I rarely spend time in Chilanga. I'm always firefighting now in Lusaka and Nakonde. So we have these cases all over. Central Province is another area again which we need to watch out. All these truck drivers, they're passing through Central Province. Copper Belt, this week will be on the Copper Belt. We are closely watching the Kasumbalesa border. There, the number of infections, we believe, may also be high. They're sending in more swabs to go in there so that they can test, but also in the testing in the facilities needs to be increased in all these places. So how do we maintain the gains which have been there before COVID?
So we will just take a break and have a look at some of the poll questions for this afternoon. And we want you to get involved as this afternoon's presentation. And so the next question, poll question 3, question reads, guiding principles for maintaining ART treatment gains in the COVID-19 era. Which of the following is correct? Do not make appointments for PLHIV to come to health facilities. Ensure safety of clients and providers while in the health facility. Limit multi-month dispensation of ART to avoid treatment failure due to drug resistance. Avoid engaging the community to avoid COVID-19 transmission. So which one of the following principles will better enable us in terms of maintaining the gains that we have made in the treatment HIV program in this COVID era? A, do not make appointments for people living with HIV to come to the health facility. B, ensure safety of clients and providers while in the health facility. C, limit multi-month dispensation of ART to avoid treatment failure due to drug resistance. Avoid engaging the community to avoid COVID transmission. What do people think would be the best guiding principle? As you may have already appreciated, the Ministry of Health has done tremendously well so far in the road to epidemic control, and a number of programs and activities are on a good trajectory. So what are some of the things that we can put in place to actually maintain that trajectory? So I see most people think safety is quite key in terms of client and facilities. Anyway, we'll discuss the answers at the end of this presentation. So I'll hand back over to Professor to pick it.
Thank you, Dr. Kozia. So as you, just the last word you said was safety. We need to ensure that there is safety first to healthcare providers. This has been the message from the leadership, all the way from the presidency, the ministers, and the permanent secretaries. Our concern is the number of infections which have been happening among healthcare workers. We know 20% overall do get infections. It's not just peculiar to our country, but we want you safe. PPE is going to be provided, but on this platform, I would like to say that let's use the PPE appropriately. There are times when someone just on the ward, they want to use all sorts of gears they want to put on. Let's use a surgical mask when you're on the wards. If you think you have someone who is infectious, those who are working in the isolation centers, let's use the appropriate PPE, the N95s, the coveralls appropriately. When are we gloves, of course. Sometimes these PPEs have been not used rightly. And also, there are times when we know that you're on the ward, even we have cases of our health workers who have been infected. They have walked in there in the isolation center without a mask. When they have put on, the coveralls, the goggles, it's been hot in there, then they've tried with their gloves after seeing patients, they're busy scratching their faces. Let's try and minimize these. These are the things that have led to some of the infections. Some of them as well is the materials, certain materials have been removed from isolation centers to where they are staying, and that also poses a risk in terms of transmission. So really the message is we want you to be safe. Physical distancing is important, triage of the patients. That's why each hospital we've recommended any of those where there is a high risk of suspicion of having COVID-19, isolate them in an appropriate area. Minimize the contacts also with the health facilities. We've encouraged people only necessary visits into the hospitals. We've encouraged also no bedsiders by the hospitals, in the hospitals. We need to up the game in terms of infection prevention control measures. Now, this is very key, friends. So safety is number one. Also added to that is, we want all healthcare workers to be swabbed. Don't fear being swabbed. We swab ourselves. If we are positive, we isolate ourselves. When it's safe to come back for work, that's when you come back. We'll reduce the transmission to our fellow colleagues. We also reduce the risk of us transmitting the infections to our patients. It's possible some of the cases that we have had, the transmission could have happened in the health facilities. We are not accusing any health worker of having deliberately infected the patient, but it can happen as long as we don't know our status. So we are encouraging all health workers to be swabbed. And we need those who are in the isolation facilities every week, every 7th day, we need to be swabbed. And we need to take the temperatures every day, the respiratory rate every day. To become breathless even after jogging, also go for a screen. Also, the month-to-month dispensation of ART needs to be encouraged. We, at a minimum, let's give 3 months. For those that are eligible, what we want is 6-month dispensation. And this also does include the TPT. Let's also have the viral load testing done for those that are eligible. Remember, our target is that we need to have September, October, mass transition of our patients on TB to TLD. But we need to have viral loads at least done within a year. So please, let's continue doing the viral load testing. We need also to engage the community. Community index testing has resumed. Training of the community health workers, then we need also the PPEs for the community health workers, community sensitization for HIV testing as well. But as we go out, let's also try to combine with some of the COVID-related messaging as well. We've seen that for Nakonde, we have employed a community model. This community model may be employed also in other areas. So as we go out there, let's give the proper information on how should they also protect the clients we are visiting against COVID. We don't want to lose someone from COVID when we have not lost them from HIV. Ensure that we are giving the same information on the policy of the face masks. Use the cloth masks for our clients who are in the community. We use the surgical masks if anyone is in the health facilities attending to patients, and where appropriate, we use the N95 and other gears. And we need also to strengthen the continuous quality improvement. It's good to see the month we are scripting or dispensation going to 74% as of April 24th in Lusaka. Now, that's what we want to see. We don't want to see rates, 40%, 53%, want to see grades. Let's give dispensation to these clients for a longer duration, 6 months dispensation. We have, of course, operational challenges. We have clients who are afraid to come to the health facilities due to the COVID-19. Some may be due for a viral load and they don't want to come. We have some who are not reachable on the mobile lines. Also, we have limited ARV storage space as we provide the month-to-month scripting. Then also we have delays in the scheduled shipments of ARVs. Sometimes the delays are on our side at the border because of trying to control. And also we've seen that because we are giving the 6 months for those on TLE, this may slow down the TLD transition. And as I said, we are on track to have the mass transition from TLE back to TLD come October, November. Dr. Sivile, I'm sure we are on track. Because having children, eh?
Yes. I mean, we just started the multi-month. This is the DSD, been more than 2 years old, as we shared.
So we'll now move on to poll number 4, so that you may also get involved. As you may know, the philosophy on ECHO is to allow for participation of the network. And so this question is as follows. The following mitigation measures will help to maintain the supply of ARVs to people living with HIV. The following mitigation measures will help to maintain the supply of ARVs to people living with HIV. A, supporting last mile distribution of commodities for scale-up of 6-month, multi-month dispensation, setting up multiple triage points at ART sites, and home deliveries through peer-run groups or private delivery mechanisms that maximize social distancing and respect patients' privacy. D, or all of the above. Okay, so let me relaunch that. Sorry about that. So that's the question. Which of the following mitigation measures will help to maintain the supply of ARVs to people living with HIV? Support last mile distribution of commodities for scale up of 6 months, multi-month dispensation, setting up multiple triage points at ART sites, or home deliveries through peer-run groups or private delivery mechanisms that maximize social distancing and respect clients' privacy. So which one is correct here? D, all of the above. Well, we have a very good attendance this afternoon, and about 184 people have connections, and we have got 92 who think that all of the above are correct, and about 5% think that multi-month dispensation would be ideal. Okay, so thank you so much for participating in this polling. I'm going to end right now and ask Prof to continue.
Thank you, Doctor. Now, these are the mitigation measures at facility level where we have to fill up the 6 multi dispensation, distribution going up to the facilities, and also setting up the triage points in our facilities. The use of technology is important this time. We need it to follow up the clients who are on these longer supplies of ARVs. And also, we need to confirm the preferences in advance with their clients. And before you initiate any voice call, confirm the safety of initiating such a call. Remember, most of the monitoring for safety is going to happen through any of these technologies, mobile technologies largely. And also, we need to identify and receive the client permission before discussing any health information. Sometimes we feel it may be safer to even just use a WhatsApp call when you're talking to these clients. At community level, home deliveries are happening in certain areas, and also community or private pharmacies as well, where people can just pick up the ARVs. And also the pop-up pharmacy will provide additional infrastructure in remote areas where people can just come in and also pick up the drugs. But as we do all these interventions, remember the physical distancing is very important. We don't want people to come and get COVID just because they've come to get the drugs at it. There are others where we have the automated lockers, and also we have the community pickup on the Copper Belt. QUIP has worked on this. So we have all these models which can help in trying to reduce the contact which we have with the patients or the clients in our facilities. We have to integrate a COVID-19 and also HIV response in the facilities. And this has been our cry, that this integration should go on. And if we do integrate the services, then none of the programs is going to suffer, the COVID-19 response and also the HIV response. We know that as of today, we have 761 cases, 192 recoveries, and also 7 deaths. I mentioned the healthcare workers, we have had 67 healthcare workers infected. And we have an estimated suspicions of 5, which could have been due to nosocomial exposure. We have recorded so far 28 HIV positive patients among those that we have had in the facilities. And of course, the outcome has been good, except one where the mortality was, of course, there one of the deaths that we had was also HIV was implicated. But overall, the people that have had HIV have done relatively well. But the quickest recovery we had, some of the quick recoveries we have had have been among those who are HIV positive, but they've been under control. HIV infection has been controlled. So it's important that we maintain the control for HIV. Someone remains suppressed, they are taking the treatment. They get the COVID, hope that even the outcomes will also be good. We released a memo on April 10th for prioritization of screening and also testing for the COVID-19. Now, this in the health facilities is key. You know that we've done a lot of mass screening. We have gotten huge numbers from the mass screening, but those mass screening, they were targeted as well. We knew the populations to go for. The people that we have lost have been the people who have been in the hospitals. We need to protect our individuals who are in the hospitals. If we have COVID in the hospital, a number of them are going to die. That's why we said, let's swab everyone who is in inpatient. Let's swab everyone who is coming into the health facility. We need to have a clean environment in the hospital. And this is going to reduce on mortality. We've given guidance over time, the different guidelines, clinical, then also the screening, and also how to manage the healthcare workers once they're exposed. This is active case finding in health facilities. This is very key. We're even saying that where we have the gene expert, let's prioritize the use of gene expert to those cases who are in the health facilities so that we can know where to move that patient to. And also mortuary surveillance. We need anyone who has died in the facility or someone who has brought in death with any respiratory symptom. They need to be swabbed. Very soon we are going to see countrywide training of swabbing the people that are dying, and also marked with that is linked to the mortuary surveillance which has been going on. Some of the trainings are going to be done virtually like here. In some, we are going to see some of our experts moving in to help us achieve the goal of screening or testing all the BIDs. There's also this concept of the vulnerable population, shielding them from COVID. We know the older age group are at risk of having severe disease and also increased mortality. We know those who are immunosuppressed, those who may have comorbidities. It could be cancers, it could be diabetes, hypertension, cardiac conditions, but also uncontrolled HIV as well. The young ones as well. These groups are a special population, whereas we are emphasizing on the positives, where we isolate the positives. We also need to know that we need to concentrate as the epidemic evolves, the pandemic evolves. Like Nakonde, where we have had some 62% positives from the samples that are run. We may start considering shielding those who are at risk of having severe disease. If it means isolating them, I don't go to see my mother anymore because I know my mother is an elderly person. I don't want my mother to catch COVID if I have COVID and I expose you. My mother is also in isolation. Both my parents are in isolation. Mr. Kampamba has the in-laws who are also have comorbidities. They're also in isolation. We don't go to see them. So let's try and shield this population so that they don't get infected. If you and I in Tumbi got the infection, Dr. Severe, you got the infection, you're likely going to fight it. Whereas these who are vulnerable, if they get the infection, they're unlikely to fight it. So as we have more numbers, colleagues, let's prepare ourselves with this concept of reverse isolation or shielding of the vulnerable populations. If we are going to reach a stage where we need to lock down these populations, I can assure you this government can do that to protect this population. Right now, it's not where we are, but we need to start right now looking at interventions of protecting this vulnerable population. We have deliberately said in the COVID center, we are not going to have the elderly ones. Healthcare workers who are above 50, in fact, we put it even at 50, above 50, no one should go and take care of the patients in the COVID center. Those who have diabetes, those who have HIV, the pregnant population as well, we've said they're not going in to take care of the COVID, the COVID positive patients. Because we want to protect this population. So let's try as much as we can do for us to avert any adverse outcomes if we had infection among these populations. So in summary, we have made great strides in fighting HIV. We are also making great strides in fighting COVID-19. But the COVID-19 may lead to us losing those significant strides which we have made against HIV if we don't handle it well. So we should capitalize on the agents of COVID-19 in accelerating certain priorities, the multi-month dispensation. We need to bring in innovations to ensure quality HIV services and appealing to those of our partners who can help in accelerating in isolation centers. Let's have the Zoom in the isolation centers. Let's have the tablets in our isolation centers so that we can do rounds with Dr. Zico right now, who is in Chinsali. We need to do a round with him. Dr. Chitalu, who is in Masaiti and going all over the Copper Belt. We need to do rounds with him virtually. Dr. Masua, who is in Levi, we also need to do rounds with him, and also Dr. Mulambi at Courtyard. So please, our appeal, the partners who can help support us, please, we are begging that we use this technology for us to improve the care. But at the same time, let's modify this with also taking care of the HIV infected. We are saddened, I think some of you may have seen on social media, of certain people who did not have access to ARVs, the truck drivers. Again, that's a dent on the program. It's also a dent on the COVID-19 response. The ministry has now said, let's get the history of anyone we are putting in our isolation facilities. Someone is HIV infected. Let's provide them with the necessary commodities which are needed. If it's ARVs, if they are due for a viral load. We have been able to do even viral loads recently, and thank you, Mr. Kampamba, for your interventions, where we have had to go into these facilities where we are holding on to certain populations and provide them with a service, HIV-related service, which is needed. But also, we need to protect ourselves. very key. Healthcare workers, let's protect ourselves. And also let's protect our vulnerable populations. My plea to all of you is let's swab ourselves. If we swab ourselves, then we are not going to take our infections, which we have, to our inpatients. Let's also protect these others who are not in the health facilities. If we have our grandparents, if we have anyone with comorbidities who is our relative, or anyone in the community, let's spread the message that we need to shield them, especially as we have more cases in the community.
Thank you very much, Prof. Great and earnest appeal. I think we've heard your cry, Prof. I think each one of us is a front line wherever we are in the community. Let's isolate our vulnerable population, health workers. Let's go and swab ourselves so that we know where we are and we're able to protect our patients and our families well. Thank you very much. Very, very helpful presentation, Prof. And I think it has shown the clear guidance on how the Ministry of Health would like us to approach the care and our services, not only in the HIV program, but as well as the other programs that the ministry is involved in. So at this particular time now, we'll just revisit our pause so that we can have now a time for questions. So that we just go through the pause again. So I'm going to relaunch poll question number 1, and then so that we can just discuss the answers. And then afterwards, we're going to invite for any clarifications, questions. I've taken quite note of a number of questions that were in the chat box, and then I think we'll respond to them as we go. So the first question is true or false? HIV epidemic control is when total number of new infections falls below the total number of deaths among people living with HIV, with both declining. Prof, the answer here, most people think that it is true. That is correct. I know you did endeavor to explain this particular epidemic control.
It's sad that 3 of them don't think so. But you're right. I think it's our goal is let's have the new infections less than the mortalities that we are having. But also important is that both should show a downward trend.
Thank you very much. The next poll question. What is needed to break the HIV transmission cycle? There's that wonderful cycle that you were able to, part of you was able to show us how that cycle is moving between men and women. And so we want the network to pick which one is the best answer here. Is it A, to ensure majority of people with HIV are on treatment, including men? Or is it B, finding new cases? C, retaining people living with HIV in care without treatment interruption? Or is it D, all of the above? So we'll give you 20 more seconds as you decide which one is the best option, whether all of them are important when it comes to breaking the HIV transmission, or perhaps either of these. Thank you very much. I will end the poll and share these results. So, Prof, most of them think that all of these are very important interventions, as you had explained.
Indeed, all these are important. Let's ensure that we put all those that are with HIV on treatment and the new cases, treat them, and also let's retain one with.
Or question 3. guiding principles for maintaining ART treatment gains in the COVID-19 era. Which of the following is correct? A, do not make appointments for people living with HIV to come to the health facility. B, ensure safety of clients and providers while in the health facility. C, limit multi-month dispensation of ART to avoid treatment failure due to drug resistance. D, avoid engaging the community to avoid COVID-19 transmission. I think most people here are already thinking on safety. Everybody wants to keep safe together with the clients.
That is, I think that was your word. So people just, and it's good that safety where we need to ensure that we have safety clients, but also including yourselves, colleagues. We need to be safe in this time.
Thank you so much. The final poll question before we allow the network to ask their questions. The final question is, the following mitigation measures will help to maintain the supply of ARVs to people living with HIV. A, supporting last mile distribution commodities for scale up of 6 multi-month dispensation, or setting up multi-triage points at ART sites, social distancing, physical distancing, so to speak, home deliveries through peer-run groups or private delivery mechanisms that maximize social distancing and and respect clients' privacy? Or is it all of the above? So which of the following mitigation measures will help maintain the supply of ARVs people living with HIV? So most people think all of these measures will help.
It's true, Dr. Koze, we need to have all these measures implemented. We said 6 months dispensation of the drugs,
Yeah.
and triage, very, very key interventions.
Thank you very much. Okay, so thank you very much for your involvement in this activity. We appreciate the network, and right now we want to just say, raise your hand on the platform so that we may be able to interact with Prof here and ask any questions, any clarifications. There was a question, Prof, that was asked. They are wondering whether there's been a role of, there's been a benefit of those people who are living with HIV and are taking ARVs and have had COVID, whether the ARVs have had any beneficial or effects on those people that are.
Excellent question. We have seen reports from especially Europe, Italy, from Spain as well, of the patients that were on ART doing better. Of course, some of them were on PIs, but a large number of them were on TDF, and the outcomes were better compared to those who are not on ART. Now, we are yet to see that in our population. Mm. We have, of course, there are some of our clients whom we've tested positive just when they are tested COVID-19 or SARS-CoV-2 positive. And we've given, one of them we gave TLD and did not recover quickly until we had to intervene and also change to lopinavir as well. So we are giving certain modifications to many patients as they present, but so far we cannot say that they are having worse outcomes, maybe because the patients that we have had are controlled. Of course, the one whom we lost had uncontrolled HIV.
Thank you very much, Prof. And then there was a question they're asking about any updates on the Zambia 2020?
Oh, Zambia 2020, we have been discussing Zambia 2020, and we are really thinking highly that we are going to do the Zambia in line with some of the seroprevalence studies. Okay. So that we can also have an understanding of the prevalence of COVID-19 in our population, how many have been exposed, how many have not been exposed. So certainly it will go ahead, just looking at the mechanism at which the environment under which it can go ahead with, then also piggybacking on that resource to have a better understanding of surveillance, nationwide surveillance.
Okay, thank you very much. We have Dr. Kongolo, who has raised a hand. Please, Dr. Kongolo, go ahead and unmute yourself and ask your question.
Good afternoon, Dr. Ziambo. Good afternoon, Prof.
Good
Good afternoon.
My question is, among the patients who were HIV positive and contracted COVID-19, in the presentation I saw it was about 26 or 27 patients. Among those patients, what was the viral load profile? I'm asking because I would like to know, is it because they were unsuppressed that they contracted COVID, or it's really independent from that? Thanks very much.
Thank you, Dr. Kongolo. So among those, we had a mix. In fact, we had 2 who were HIV infected, but ART naive. They were started on ART while in the facilities, and both of them did well. We had also 3 who were not suppressed. 2 of them did well, recovered. 1 of them did not do well, and we lost that one. The rest, we did not have I cannot reveal the viral loads which were there after they were admitted to the facility because the bloods were drawn, but according to their report, they were doing okay. We had, of course, the CD4s which were high, but we did not have a viral load. So we can say it's a mix. One of them whom we lost was failing treatment and also had other comorbidities. Then the 2 who were naive, ART naive, they did well and they've been discharged.
Thank you very much. Dr. Daniel Mwamba. I hope, Dr. Kongolo, that answer was okay.
Yeah, the answer was clear. Thanks very much.
Thank you very much. Dr. Mwamba.
Thank you, Doc. Good afternoon, Dr. Ziambo and Dr. Mulenga.
Good afternoon.
Yes, so I've been following the presentation and particularly interested in the fact that we need to continue providing the HIV service in the COVID era, of course, with a minor adjustment in the way we've been doing things. My question is on community-based activities. We've been going out to do index testing, before the tracing, and we've been having various community-based activities. That those activities were put on hold. I want to know if there's any change in that decision, or we still hold on to those activities.
Thank you, Dr. Mwamba. I know you asked that question even in the previous meetings. Thanks, Prof.
Yeah,
the patient has come back.
Thank you, Doctor, for your question. As I said, we are working on a document on continuous health service delivery in the COVID era, and that includes the community activities. So we'll be informed in the coming circular on what we can do even in the space of COVID. Community activities, yes, they will continue.
All right, thank you. Prof, I've seen a few questions here. I might read them out to you. There's a question on those that is screen positive. Are they being screened for TB as well? I know our guidelines have got something that they said about evaluating for TB as well. Any comments on that?
So as you know, recently we have been using the nasopharyngeal and also oropharyngeal specimens, and we have considered now the use of sputum as well for COVID, for SARS-CoV-2 testing. And with that same sample, we'll be subjecting it to both the COVID and also to both SARS-CoV-2 testing and also to MTB testing as well. We are doing also in certain, almost in all the, in Levy and also in Courtyard and in Dollar facility, we are doing the X-rays as well, baseline X-rays. And if there is a picture which is suggestive of TB, we are also injecting them on TB. We are supposed to inject them on TB. So far, we haven't had any who has shown any of those symptoms. Of course, we have had patients whom we have had with TB and they have COVID. Those are continued treatment, but we haven't had any patient whom we diagnosed with TB while in isolation.
Okay, thank you so much, Prof. And I think what I'm also reading is that we still need to make a differential diagnosis of any patient that we are actually screening as we are seeing them. They will probably come with a complaint at our facilities. We still need to address that complaint that we find in our facility. So the other questions, I'll just read them. We've got another question. They're asking treatment of COVID-19 positive but asymptomatic. What are we giving the asymptomatics? Are we giving them any kind of treatment? And then also another question is managing burnout in our health workers. Are we doing that? Then also PPE supplies to facilities in rural areas. Then also somebody also wants to find out the Madagascar concoction. Are we planning on doing something with that as well? Maybe you could respond to those before we
now,
get back.
You know, I've been telling the team here, Dr. Sivile, Dr. Foroshi, Dr. Mpeta, Dr. Kozia, have now been subjected to just answering political things, political questions. They even want to throw me out of seeing patients. Some of these are political questions you asked, and I'll try to answer them as much as I can.
Yes, Prof.
We start with the asymptomatic. We treat these patients based on their presentation, and also we try and use some of the investigational drugs. Largely what we are using is hydroxychloroquine, and also we are using azithromycin, some of them are amoxiclav. And we have enrolled into some trials as well. We are enrolling into the Solidarity trial, which is a WHO-led trial of various investigational drugs. So some patients on some investigational drugs, including largely hydroxychloroquine. There are some, of course, we are supposed to use ivermectin as well. Of course, the other drugs which we do not have available. We are also enrolling into 2 trials which are going to look at the prophylaxis among healthcare workers. And they are using hydroxychloroquine in different doses and also different durations. That's how we are managing these cases. But also we have had some where there are some who have been very sick. We've tried a lot of things. Some things we've tried. Right now we're even trying, we're giving patients even the convalescent plasma. We are harvesting plasma from those that have recovered. But we screen for the virus using blood. We do PCR testing, and also we screen for other infections, including HIV. In that plasma, we are giving to certain individuals, either those who have delayed recovery or those with severe infection. So we are doing a lot of things, investigational, a number of them, and looking at each individual as they present. Managing burnout. This is very key to manage this burnout. What we have devised, the system we have devised for Lusaka and Copperbelt is that we have specific isolation centers, and we have a group of people who are managing those. They spend 2 weeks in working, 2 weeks under isolation, then they go home for a period of 2 weeks, then they come back. Again, we don't want to exhaust and expose many healthcare workers because we may have many more cases coming. So as we move on, we are going out to get on another pool. Now, what we have seen is the other, like we're going to UTH. If I'm doing a round in UTH, I see very few patients. But Dr. Sibile, when you're on call now, you're smiling. So we have done that deliberately so that Dr. Sibile does not burn out now. When it's time for him to go in there and see the patients, at least to be fresh enough. Those again who are in the facilities, we also have this rotation system. But importantly, what they need, friends, it's very difficult for you to be isolated in there for 1 month. They need a lot of mental and also psychological support. That is very key. In terms of physical, where burnout is not what we are seeing now. What we are seeing is just mental, and they need that psychological support. And for us to be there to provide any of the things which are needed. PPE supplies to facilities in rural areas, because PPE is now it's being supplied from MSL, it's not at the ZNPHI, and it's according to the orders which are made at the province, and the province has its distribution to the facilities. So it's now following the same channel for distribution of commodities, instead of setting aside a separate system for supplies to be delivered to the facilities. Madagascar, whatever COVID organics, we have been approached, and a letter came to the country, to the government, with a donation from Madagascar. And of course, we have given a stance, and the minister has on a number of occasions also indicated that we follow all the investigation of drugs closely. But for us to bring in a drug, we need to know what has been done around that drug. We have scientific data to support the use of that drug. How safe is the drug? What is the dose for that drug? What is the duration? In which population is it indicated? So far, we do not have any of those answers from the COVID organics from Madagascar. And we, as of now, it's not a drug which we are thinking of getting.
Thank you, Prof. You actually competently answered most of those questions. Yeah. So I don't know what that says.
Well, don't tell me.
Okay, so I will ask George Health Center. We have a few minutes, about 3 minutes before we can call this a wrap. So George Health Center, you raised your hand. Would you like to unmute yourself and go ahead and ask your concern?
Hello.
Hello.
Hi, Dr. Chanza here. I wanted to find out if we have designed any studies with regards to people that are living with HIV, to follow them up maybe and see how how they turn out, if the disease will get worse in them or something like that. Basically, is there anything designed to follow up people living with HIV/AIDS with regards to how they respond to the COVID-19?
Very important question, Prof.
So we are working on a protocol, and this is just a Zambian protocol on the people living with HIV, where we follow them and look at outcomes, but also including other biomarkers for those who are HIV infected, especially those which look at the immune markers as well. So that is what we are looking at and designing a protocol around that. It's a country-specific protocol. It's not enrolling into one of the trials for HIV infected.
All right, thank you very much. I've seen a question raised by Dr. Kunda Chosakunda. Could you kindly ask your question? I didn't quite understand it on the chat. Maybe you could just unmute yourself and ask. And then I also asked Dr. Bosco. Could you also just make a voice call? Unmute yourself and ask the question. Are there any other questions, concerns from the network, so that Prof here may be able to respond to those? Dr. Bosco.
Good afternoon, Prof. Yes, good afternoon, Prof. Good afternoon, Dr. Kozia. My question was on the 50 years restriction for healthcare workers to attend to patients in the COVID center. Do we have any data, any local data, which can support that restriction that some of us who are above 50 years cannot attend to COVID patient in the COVID centers? Thank you.
My friend, how are you? I know
You've
you're
been
not 50
excluded.
yet. I know you're not 50 yet, my friend.
I'm above.
And if you are with Dr. Mwango, please pass my greetings to Dr. Mwango if you're still working within the offices.
Thank you.
We do not have any evidence. It's just a protective mechanism which we have put in place. You know, certain things you don't need to wait for evidence. You don't need to wait for our friends to be severely affected. And that's why we have put in those recommendations. And again, it's a recommendation. There are certain individuals who can be, especially if you're above 50 and you have comorbidities as well, it's just trying to protect. We also have had some individuals who do not fit that risk category and they've been uncomfortable going to see the patients, and we have also eliminated them. So if we have a 62-year-old man or female who thinks that I can help in fighting this and they understand the complexities and also our fears, they are welcome.
Thank you, Prof. Dr. Chisakonda.
Yes, good afternoon, Prof. Good afternoon, Dr. Kozia. Thank you for the great presentation. Yes, so my question was the client or the patients that are being swabbed in the private healthcare facilities or in the health facilities, how much information are we giving them regarding the swabbing, why we're swabbing, when do they get their results? I'm putting into consideration a hypertensive client or patient who's admitted. And as we know, most of these patients are there alone without any bedsiders. So how much information are we giving them to avoid any mental health issues?
Dr. Chisakonda, thank you so much for your kind words and also for your lovely question. I know, when we started this, it's fast track mode where we just needed to speed up with the testing, avert mortality. And right now the team developed a pre and also post-test counseling piece, which is included in the training package. Dr. Kozia and team will be rolling that out. But also currently, anyone who is swabbed, they need to know why they are being swabbed. Of course, the response has been great because people know so much about the COVID. But also when the information is given, it has to be given in a manner which is okay and friendly. We have made some mistakes, of course. There's certain times when you have not informed patients of their results and maybe they have hit them on social media and all that. But we are avoiding all those cases. We need to inform the one who had the test done, the result, and also know where the outcomes, where the isolation facility is for them to be moved. When are we going to give them results? Now, this has been very challenging to us and also sometimes very moving and emotional, where we know that some healthcare workers are swabbed, some of our sick patients are swabbed, and the results have not come on time. We are trying so hard to increase the turnaround time, to reduce the turnaround time. We are moving in with having the gene experts so that those who are on the wards, they can have access to the results within 2 hours or so of the test being done. We are also, I'm sure you've seen, opening up of various labs. TTRC is on board now. We have the Siders lab will start testing as well. We have also the MACHA testing. We have in UTH, we have the real-time PCR, but also we have the gene expert as well. PCO here, pediatrics, they'll start testing as well. So we are mopping up. Chisali's testing now, both huge PCR are being done and also on the gene expert. We are trying to increase the testing, and you're going to see that in the coming days, maybe some organizations are going to come up with equipment for regions where I think that the testing is not adequate. We are trying to roll out the testing. But also, if you know of any donors who can help us, especially with reagents, please bring them on so that we don't run out of the reagents, both for Gene Expert and also for these huge equipment, the PCR equipment which we have.
Thank you, Dr. Chesakunda. I'm sure you'll be getting in touch with the donors that you identify. Yeah? Looking forward.
Thank you, I will.
Okay, so we've run out of time. I've got 3 hands that have been raised. Prof, would you like to answer those 3? Okay, so those will be the last 3 that we will allow. So we'll just allow them to ask in a row. Matthew, could you go ahead and unmute and then make a comment or a question?
Thank you, Dr. Koza, and good afternoon. Good afternoon, Professor. So this is Dr. Matthew Ngambi. I'm happy to see both of you there. And my question is not so much a clinical question, but Prof, it's a question on the guidelines, basically. And I am not so sure that you have spoken to this question. If you have, I apologize, but I would be grateful to just get your comments on it still. And it's to do with the use of masks. I see the both of you, one is wearing masks, one is not. So my question is, do we have specific guidelines that people can follow? When, where, how do we use face masks? Is this a mandatory thing? Is this a recommendation? Because sometimes we have seen really scary things that, or maybe sometimes on social media where even the police are arresting people for not wearing masks in personal vehicles and things like that. So is there something quite clear that we can all follow? Thank you.
Dr. Ngambi, that's a political question. It's mandatory, sir, for people to wear masks in public places. And Dr. Kozia has now put on the mask because this is a public place where we are.
Nice one. Thank you.
So, sir, yes, doctor, we know that, you know, when something is, when the head of state declares something, and of course he said mandatory, just the implementation. And also sometimes some of these things are abused even by ourselves on how to implement them. Of course, if you're alone in the car, I mean, it does not make sense. You're alone in the car and you're putting on a mask. You're fearing yourself or what? So I think it's the interpretation of the guidance or the which has been given from the head of state. As in the facilities, there are guidelines which are there. Dr. Kozia, Dr. Sivile, Mr. Kambamba, you finished all those guidelines on where to use PPE, which type of PPE to use and where. These are ready, they have been distributed in facilities. We need more focus for printing. Any partners who can help with printing so that they are stuck in various units in the hospitals, that we know which PPE to use in which area and also in which points.
All right, thank you very much. Galaxy S7 Edge and then Kabwe Central Hospital. So Kabwe Central Hospital, would you like to ask a question?
Yes, please. Good afternoon, Dr. Koza. Good afternoon, Professor Mulenga.
Good afternoon.
Thank you. This is Ringo from Kabwe Central Hospital. Ringo from Kabwe Central Hospital. My concern is about the newly initiated. We were told that once we initiate somebody on LRT, we need to give them 6 months dispensation, then make a call at 2 weeks, at 1 month, and at 3 months. I want to get from you, Doc and Professor, is it really true that we should just make a call, or they should come that we physically review them? With the COVID-19 guidelines, we're told once we initiate somebody, then we give them 6 months drugs and then review them at 6 months.
Yeah, I'm sorry, Ringo, for that, my brother from Kabwe. We are supposed to, only the stable patients are the ones who are supposed to give the 6 months worth of ARVs. I know Dr. Sivile maybe is the one who gave that guidance.
No.
Thank you very much. Actually, I was about to bring that up. Yeah, so that came to our attention, the Central Province. Yeah, so that was against what we had given. I know last week there was a team which was in Central Province, Dr. Mwemba and others who tried to correct the situation. So they did inform us, we've spoken to the partner, and I think if there's anyone from those who spread that news on the platform today, I think they should retract that. So new patients should not be given 6 months. They follow the normal way. You give a month's supply and 2 weeks you review. Yeah. So I think that information came to our attention. Thank you very much for being here.
All right, thank you very much. Any comments, Prof? Though there's been one comment here from Dr. Ngwenya. She was concerned that if there are any, she wants to find out if there are any plans to have an isolation for pediatrics on.
For Lusaka or the whole country?
Particularly, I think she's talking about Levi-Manoas because
No, doctor, apparently we are not going to, we have no plans of setting up a pediatric specific isolation facility. Now, if you look at what is happening just even in Levi, we have a lot of staff there. If you open up so many sites, you need again many more staff. Even when you have one patient, you may need EHTs, maybe 2 EHTs for one patient. You may need 4 nurses for one patient, maybe 2 doctors for one patient, maids for one patient. If you have 15, the same number of staff. We are trying to limit the number of isolation facilities because the exposure and also the amount of human resource needed is going to be high. What we are encouraging is we have a pediatrician on board, and that pediatrician who is there, based there, is the one who is going to take care of the pediatric cases. We are not going to set up a pediatric specific isolation center.
All right, thank you very much. We may go on and on and on. I know, I think Prof has attempted to address some of the major questions and concerns from the network. I think we will have to call it a wrap here, and I would like to thank Professor for coming through and just giving us a clear vision on how the program HIV would like to see us respond in this COVID-19 situation. Prof, any last words?
My last words to you team, first of all, is to say thank you for your work for both HIV response and also the COVID response. We want you to be safe. At the same time as you keep yourselves safe and we protect our patients also from infections, let's not lag behind in delivering the HIV-based interventions which are going to help us achieve HIV epidemic control. To me, this is my way. Be safe, but let's maintain the HIV and other services even during the COVID-19 pandemic.
Thank you very much. Next week, we will not have the session because it will be Africa Freedom Day, 25th May. And so our next session will be on the 1st of June. And on this session, we'll be looking at the topic COVID-19 question and answer session. And the presenter will be Dr. Hachambwa. So what we would like to, from the network, is that we would like you to write all your questions that you would like to see responded to. It will be a question and answer session. And so this, we'll use your questions and give some responses in the next 2 weeks. And so we want to thank you all. You send your questions to myself, to Dr. Sombo, to Mr. Davis Kampamba, so that we may be able to compile them and be able to give an exhaustive, well-researched response with evidence. So that's what we're going to have in 2 weeks.
And so some of the responses that we have not responded to on the chat, we'll be able to transmit to the relevant authorities. I know I'm aware about the concern about results feedback and the potential of using the eLab system. I think the team is working on that, and then we will be able to just address and just share the concerns that you have given to us. Otherwise, it's been a lovely afternoon. Thank you for your involvement, your participation, and your active participation. We will see you on the 1st of June, and have a good day. Thank you.
Thank you.
Thank you. Thank you so much.
Thank you.